We'll discuss today uveitis associated with Behçet disease. As you know, patients with Behçet disease, you have to know first why the disease is called Behçet. Behçet is a Turkish dermatologist who describes the disease for the first time. He's not the only one, but the disease was also described by another Greek ophthalmologist called Adamantiadis. So to be fair, the disease should be called Behçet Adamantiadis disease. As you know that the disease or the patients are clustered along the Silk Road. You know the Silk Road? طريق الحرير. طريق الحرير اللي هو silk traders were using for silk. And this road extending from the far East Asian to Mediterranean basin. Therefore, most of the patients with Behçet disease are present along this area. Turkey has the highest prevalence of the disease, but the disease is common in other countries like Japan, Korea, China, Iran, Saudi Arabia. The disease is very rare in Western countries. So this is a disease, according to epidemiology, which is present in our region. If you look at the major changes that you see in a patient with Behçet disease, there are three major changes. Patients with Behçet disease, they have hyperfunction of polymorphonuclear leukocytes. All the manifestations that we see in the eye and in the skin are the result of the hyperfunction of polymorphonuclear leukocytes. I'm going to discuss this later also. So the polymorphonuclear leukocytes of these patients, they have more ability for chemotaxis to migrate to areas of irritation. They release more oxidative stress markers and so on. The second phenomenon is vasculitis with endothelial injuries. Frequently, I explain this to our residents, that we see patients with Behçet disease whom the first manifestation of the disease was deep vein thrombosis. This is reflecting vasculitis with endothelial injuries. But unfortunately, many of the medical doctors who care about these patients, they don't think about Behçet. Although I think that any young patient who present with deep vein thrombosis, Behçet disease should be ruled out. There is also an autoimmune response. To understand the pathology or pathogenesis of this disease and how does it differ from other uveitic entities, we did many studies to analyze the aqueous humor samples from patients with active Behçet disease and to compare it with other uveitic entities such as Vogt-Koyanecki Harada disease, HLB27 uveitis, and sarcoidosis. So as a whole, you can divide these diseases into two groups: acute non-granulomatous and granulomatous. Acute non-granulomatous would be Behçet disease and HLB27 uveitis, and granulomatous, it will be something like sarcoidosis and VIC-H. So these are examples of these papers that we recently published. I'm going to give a summary of these papers. If you look at the cytokines, interferon gamma is an important cytokine released by T helper 1 cells. It is a marker of T helper, as you know, there are T helper 1, T helper 2, T helper 17. It's a marker of T helper 1 immune response. And as you see here in our studies, in patients, in all uveitic patients, the levels are elevated. When you compare Behçet disease with HLB27 and VIC-H disease, you can see that patients with Behçet disease have the highest excuse me. So patients with Behçet disease, they have the highest levels of interferon gamma. What does this mean? It means that the T helper 1 immune response is more potent in patients with Behçet disease compared to HLB27 and patients with VIC-H disease. Another important cytokine, because these studies helped us to find out the most important and the most potent drug to treat Tumor necrosis factor alpha is an important, very important pro-inflammatory cytokine produced from activated mononuclear phagocytes or T cells. It plays a central role in inflammation. How? It induces the expression of chemokines, adhesion molecules, other pro-inflammatory cytokines involved in the prolongation of inflammatory response. If you look at patients with uveitis compared to controls, and you can see here that uveitis patients that had higher levels of tumor necrosis factor alpha. Now, if you compare Behçet disease with HLP27 and VKH, you see the highest level of tumor necrosis factor alpha is present in patients with Behçet disease. What does this mean? That biologics that can target tumor necrosis factor alpha would be most effective in patients with Behçet disease. You agree?
Yes.
So this finding supports the clinical evidence regarding the favorable effect of anti-TNF-alpha therapy for refractory uveitis associated with Behçet disease. And if you look at the efficacy of biologics that target tumor necrosis factor alpha, you'll see they are less effective in VKH disease than Behçet disease. Now, we looked at our studies also at chemokines. What are chemokines? Chemokines are low molecular weight cytokines. They act by attracting and activating inflammatory cells. And they are divided into several groups. But here we studied neutrophil chemoattractants. I told you that patients with Behçet disease, they have hyperfunction of neutrophils. We wanted to see if this is really translated at the level of chemokine levels. So we have a group of chemokines that act specifically on neutrophils. And neutrophils, they express two receptors called CXCR1, CXCR2. So we looked at CXCL1, 2, 5, 6, and 8. All these neutrophil chemokines, they act specifically on neutrophils. So let us look. If you, this is dark blue is Behçet, this is HLP27, then we have VKH and sarcoidosis. So the highest levels of this neutrophil chemoattractants are present in HLP27 and Behçet. Look here, very low levels present in the green bar and in the brown bar in sarcoidosis and VKH. This is another proof that neutrophils are playing a central role in the pathogenesis of VKH disease. And this can help us to treat this disease. If we have blockers for these receptors, CXCR1, CXCR2, which are specifically expressed on neutrophils, on which these chemokines are acting. So, and the highest level of GRO-alpha, GRO-alpha had the highest levels, indicating that GRO-alpha in the eye is a major chemoattractant for neutrophils. Is that clear?
Yes.
Now, we looked at T helper chemoattractants. There are 3 T helper 1 chemoattractants that act on T helper cells. These are called MEG, IB10, and ITAC. And then, if you look here at IB10, which is the most important, the highest levels were present in Behçet and HLP27. So you see, all with non-granulomatous uveitis, they are having more or less the same phenotype compared to granulomatous disease, which means that if blockers for T helper 1 chemoattractants will be important for Behçet disease. There is another 2 important chemokines called fractalkine or CX3CL1 and the other one CXCL16. These are mainly acting on T helper 1 cells. Look at their levels. The highest levels were in Behçet and HLP27 and less levels. So again, this is another proof that T helper 1 cells. So we can summarize here. Behçet disease tends to be mediated by interferon gamma, which is a product of T helper 1 cells. It's also mediated by chemokines that act on T helper 1 cells. This is another proof. And it is a disease which is also augmented by tumor necrosis factor alpha, and neutrophils are playing a major role. So if you want to treat Behçet disease, you have to focus on these mediators. How about HLA typing in patients with Behçet? It is known that HLA-B51 is strongly associated with the susceptibility of Behçet disease in many ethnic groups, suggesting a genetic component. It is suggested that HLA-B51 is implicated in neutrophil hyperfunction. That's why the relation with Behçet disease. How about clinical manifestations of the disease? Major manifestations. Oral ulceration is the most common systemic manifestation, 98%. That's why the criteria requires the presence of oral ulceration. Skin lesions, 87%. Genital ulceration, 73%. Eye lesions, about 70%. About 70% of patients with Behçet will have eye lesions. And post-pathology test in 44%. Minor manifestations are arthritis, epidermitis, gastrointestinal lesions. The manifestations the gastroenteritis might mimic inflammatory bowel disease. Central nervous system, we see patients who have Behçet of the central nervous system. And vascular lesions like Debvin thrombosis. For the diagnosis of Behçet disease, there is no diagnostic lab test. It's only clinical diagnosis. And we use the criteria proposed by the International Study Group for Behçet disease. The criteria requires the following. Recurrent oral ulceration. Why? Because recurrent oral ulceration is present in almost 100% of patients with Behçet disease, and usually this is the first manifestation of the disease. So recurrent oral ulceration is an essential symptom, plus any two of the following: genital ulceration, eye lesions, skin lesions. So this is the criteria to diagnose Behçet disease. Pathology test was required for as one of the criteria. However, in our region, pathology test is not very valuable. So what is pathology test? Pathology test indicate skin irritability. That if you puncture the skin with a needle, then you will have a septic erythematous nodule or pustule of more than 2 millimeter diameter, which is observed 24 to 48 hours after puncturing the skin with a sterile needle. It consists of initial accumulation of neutrophils, followed by mononuclear cells at the site of the positive pathogen. The ocular inflammation develops in about 70% of the patients. This is based on Japanese studies. It seems that this percentage is lower in other countries, including our country. Skin eye manifestations appears later than oral ulceration. That's why it's very important to have history of oral ulceration in patients with Behçet disease. It is bilateral, rarely unilateral. But keep in mind, it is non-granulomatous. I have seen patients with mutton fat KPs misdiagnosed as Behçet disease by even university specialists. So typically Behçet is non-granulomatous. If you have mutton fat KPs, it's not Behçet disease. Correct? So it is non-granulomatous. It is recurrent and explosive. What does it mean, explosive? It means that severe panuveitis, anterior segment inflammation, posterior segment inflammation, and severe vitritis. Hypopyon is present in about 1/3 of cases, and the hypopyon of Behçet is distinguished from that of HLA-B27 because the cells in Behçet disease hypopyon moves easily, and the hypopyon moves with eye movement. However, in HLA-B27, it is organized, it is sick, it does not move. The patients have also severe vitritis. However, the main cause of visual loss is recurrent vaso-occlusive retinal vasculitis that will end in retinal atrophy and optic nerve head atrophy. Patients with Behçet disease, active disease, they have retinitis patches. Retinitis patches can be multiple, with or without intraretinal hemorrhages. They are silent on fluorescein angiography, and they resolve without scarring. Cystoid macular edema is common, inflammation of the optic nerve head is common, and inflammatory retinal vein occlusion is characteristic. If we see, as I'm going to explain this later, if you see a case of inflammatory branch vein occlusion, you have to strongly suspect Behçet disease. Fundus fluorescein angiography, in our experience, is very useful to confirm the diagnosis because it is very typical. All the blood vessels are leaking, optic nerve will leak, but specifically all capillaries will leak. This is a phenomenon which is not existing in other uveitic entities except in Birdshot. Of course, fluorescein angiography is useful to diagnose ischemia as a result of occlusive vasculitis. I'm going to show you examples. I hope by the end of this lecture, no one of you will miss a case of Behçet in the emergence room. So this is a case of hypopion. The hypopion is fluid, it moves with eye movement. Then, as I told you, one of the cardinal manifestations of activity is this retinitis patches. It can be multiple, with or without intraretinal hemorrhages. These are typical early changes for activity in patients with Behçet disease. Then fluorescein angiography. You will not see this in other uveitic entities, that all capillaries are leaking. See, each capillary is leaking, and of course you have leakage from the optic nerve head in this patient with severe Behçet uveitis. Another case, I'm going to show you many cases, inshallah by the end of this lecture, all of you will be very familiar with the diagnosis and the treatment of Behçet disease. So this is a patient with multiple patches of retinitis. In fact, frequently these patches of retinitis are misdiagnosed to be viral retinitis. And this is, of course, seen in areas where Behçet is not common. I still remember this story many years ago during one of the Moorfield uveitis courses. There was a case presented by residents at Moorfield Hospital of a patient with multiple patches of retinitis like this, and they treated the patient with multiple courses of antiviral, and the patient was not responding. So I told them, this is Behçet disease. They kept quiet, but it happened, it was just chance that my colleague, Professor Marwan Al-Ammo, he visited Moorfield Hospital, and during his visit, he was in the clinic with them, and they told him this patient, it was diagnosed by Abu Asrar when he was here during the Moorfield uveitis course. For people who are not familiar with Behçet disease, they will treat this as viral retinitis. So these multiple patches of retinitis are highly suggestive for Behçet disease, and look at fluorescein angiography. Another example, it is an early sign of a flare-up. These patches of retinitis with the characteristic fluorescein angiography. Again, like in this patient, it can be many, and with also intraretinal hemorrhages. Another example of typical fluorescein angiography. Again here it can be similar to that of toxo retinitis, but fluorescein angiography is highly characteristic. Another example of a patient with vasculitis, vascular sheathing, and multiple patches of retinitis. Retinal vasculitis. Patient has severe vitritis with retinitis in the macula. It is really an emergency situation when retinitis involves the macula. This is a patient with mouth ulcers. Again, as I told you, inflammatory vein occlusion is highly suggestive for Behçet disease. So this is a patient who had venous congestion and tortuosity along the inferior arcades, patches of retinitis, vascular sheathing, which indicates vascular sheathing is a hallmark feature of vasculitis, which indicates vasculitis. If you do fluorescein angiography, you see delayed filling of the infotemporal vein. supporting the diagnosis of infratemporal branch retinal vein occlusion. In a course that I was in Italy, uveitis course, I was talking about Behçet disease, and ophthalmologist asked me, when do you say inflammatory vein occlusion or branch vein occlusion? I told her, signs of vein occlusion, blood vascular sheathing. This is the diagnosis of inflammatory vein occlusion. Manifestations of vein occlusion plus vascular sheathing. This is automatically should be inflammatory vein occlusion. Like in this patient, and the patient also had ischemia. So this is another patient with very aggressive retinal vasculitis. Some people, they diagnose retinal vasculitis without having this vascular sheathing. Vascular sheathing is a hallmark feature of retinal vasculitis. It represents perivascular inflammatory infiltrate. So the patient had retinal vasculitis and signs of infratemporal branch vein occlusion because there is delayed filling of the infratemporal vein. Another example, vascular sheathing, signs of supratemporal retinal vein occlusion, and what do you see here? Do you have here fourth-year resident? What is this? These are collaterals. We still use that the patient had vein occlusion, branch vein occlusion. These collaterals are pathognomonic for branch retinal vein occlusion. So the patient had inflammatory vein occlusion because he had vascular sheathing. This is another example of supratemporal vein occlusion in Behçet disease, infratemporal, but this is a very dramatic example. Patient had, you agree this looks like central retinal vein occlusion?
Yes.
Hemorrhages in four quadrant, but you agree that the patient had vascular sheathing here? So the patient had central retinal vein occlusion, inflammatory central retinal vein occlusion because of Behçet. I think I'm going to show you the effect of treatment later on for this patient. So a patient with Behçet, if you have recurrent attacks of uncontrolled inflammation, they will have severe ischemia, as you can see here. Macular edema is a common feature of the disease, as you can see with OCT, and this is the end stage. If you don't control the inflammation in these patients properly, they will end with blindness due to retinal atrophy, sclerosis dehiscence, and optic atrophy. Fortunately, we don't see this anymore because of the recently available drugs, mainly anti-TNF alpha agents. In fact, years ago, one of the first grand rounds I attended here at Kekaj, when I came to the country, was given by a vet specialist, and the main message was that patients with Behçet disease, they become blind, whatever we do for them. This is not correct anymore. With the availability of drugs, potent drugs, mainly anti-TNF alpha agents, we can prevent the blindness in most of these patients with Behçet disease. We don't see this anymore. Retinal atrophy, sclerosis dehiscence. So the treatment. So the main goals in the management of Behçet attacks is resolution of intraocular inflammation, prevention of recurrent attacks, achievement of complete remission to preserve vision. There are many drugs that are used in the past that I'm going to review with you. First, corticosteroids. I need one of the residents to read this statement. Can you please read it?
Systemic corticosteroids monotherapy must be avoided.
You cannot treat Behçet uveitis with steroids alone. However, I'm still seeing patients treated in big hospitals with Behçet treated only with steroids. You cannot treat Behçet uveitis alone. The patient will never respond to steroids alone. They will become blind with steroids. Is that clear?
Yes.
However, you can use steroids in patients with active disease in conjunction with another medications and to taper it to a safe level later on. Cyclosporin A, we used to use cyclosporin A years ago for most patients with Behçet disease. It blocks the senses of interleukin-2. Interleukin-2 is a potent T cell proliferative cytokine. There was an impression that it was the most effective drug. However, nowadays you have better drugs. And the starting dose was 2 to 5 milligram per kg per day. But keep in mind that there are several side effects. That's why we don't use it as frequently as before. The most important is renal dysfunction, neurologic abnormalities, hypertension, hyperlipidemia, increased body hair, gastrointestinal disturbances, higher incidence of neuropathic disease, and gingival hypertrophy. That's why we don't use it as frequent as before. Tacrolimus is another drug which is related to cyclosporin, same mode of action. It inhibits the activation of T cells by a mechanism similar to that of cyclosporin, and the side effects are similar. Imuran is used frequently by rheumatologists. They like to use it for patients with patient but for eye inflammation, we don't think that it is as effective. So Imuran or azathioprine is an antimetabolite. It is effective in controlling progression of patient disease, but this is systemic manifestations. You can use triple therapy combining azathioprine, cyclosporin, and steroids. Colchicine. Colchicine is the most effective drug to control mucocutaneous disease or patient disease. So patients who have mouth ulcers, painful mouth ulcers, skin lesions, genital ulcers, they respond very quickly to colchicine. How does colchicine act? Remember I told you, in patients with patient disease, you have hyperfunction of neutrophils. So colchicine acts by inhibiting neutrophil migration and phagocytosis. This is its main mode of action. It inhibits neutrophil endothelial cell interaction, so it will reduce damage to endothelial cells. But colchicine is not effective for eye disease. It's mainly on skin manifestations, oral ulceration, genital ulceration. Interferon alpha 2A, in fact, the one who introduced interferon alpha 2A to treat patient disease, توفى الله يرحمه قريب, Professor Manfred Zroth. Professor Manfred Zroth from Germany, he is well known to be the father of interferon alpha 2A to treat patient disease. And he spent his life trying to convince people that, and without him, the use of interferon alpha 2A for patient disease would die. But for his persistence and his publications led to everyone in ophthalmology and uveitis community to know that interferon alpha 2A is one of the best drugs to control patient disease, and has an advantage that after you treat the patient and after the patient becomes quiet for a long time, you can stop it and the disease remains quiet. Unfortunately, in Saudi Arabia, interferon alpha 2 is not available because it has also another good indication. Patient with resistant uveitic macular edema, interferon alpha 2A is very effective. We tried to get it in our pharmacy, but it is not available in our country. So when the German group started using it, they were using very high dose, 6 million units subcutaneous daily as a starting dose. Then other groups used 3 million units 3 times a week. And we hope that the pegylated interferon will be available, which can be given once a week. But there are some side effects, flu-like symptoms. I still remember Professor Manfred Zroth telling that if the patient complains of flu-like symptoms, he knows that the drug is effective. Yeah. It's a sign that the patient is responding. So flu-like symptoms, mild alopecia, leukopenia, itching, development of autoantibodies, autoimmune thyroiditis, psoriasis, depression, all these are complications of interferon alpha 2A, but can be reversible by reduction or discontinuation of the treatment. As I told you earlier, in the pathogenesis of the disease, that the pro-inflammatory cytokine, tumor necrosis factor alpha, is heavily involved in patient disease. We showed this by our analysis of the aqueous humor. And Tumor-necrosis factor alpha is a major pro-inflammatory cytokine leading to upregulation of other cytokines, chemokines, and adhesion molecules. So, if we target tumor-necrosis factor alpha, we know that this can be very effective to control uveitis patient disease. And in fact, currently, at least in our experience, we don't have experience with interferon alpha 2A, but in our experience, infliximab is the most potent drug to control active uveitis with patient disease. And it helped us to preserve the vision of many patients for years. Not only this, but these patients on interferon alpha, on infliximab, they can undergo cataract surgery very safely without flare-up of the inflammation. So what is infliximab or Remicade? This is a mouse human chimeric immunoglobulin G1 monoclonal antibody. So part of the molecule is of mouse origin. And it neutralizes both the soluble and the membrane-bound TNF-alpha. You know that the TNF-alpha, when it is produced by the cell, it remains membrane-bound. But then, under the effect of some metalloproteinases like ADAM17, it becomes as a soluble one in the circulation. So infliximab blocks both the membrane-bound and the soluble forms of TNF-alpha. We give it as intravenous infusions of 5 milligrams per kg over 2 hours. We start at week 0, then another dose after 2 weeks, another dose between the second and third, another 4 weeks, so it is about 6 weeks. And then in the past we were giving it every 8 weeks, but we found that many patients, they have flare up at a few days before the 8 weeks infusion. So when the disease is still active, we give it every 6 weeks. And then we prolong the interval. The side effects are infusion reactions, but the most serious side effect is reactivation of tuberculosis. That's why before we decide to give infliximab to a patient, we do tuberculin skin test and we look very carefully at it. Because if the patient has positive tuberculin skin test, then you have to give prophylactic treatment with INH. If you look at the literature, if you look at other places, you will see several cases of tuberculosis induced by infliximab. But alhamdulillah, so far at King Abdulaziz University Hospital, we never had a case of Miller tuberculosis induced by infliximab because we look very carefully at tuberculin skin tests in these patients. So reactivation of tuberculosis is a major complication that you should avoid by doing tuberculin skin test. If it is positive, then the patient needs to receive prophylactic INH. Any infections can develop as a complication. It can cause also demyelinating diseases, so you should not use it in patients in whom you suspect that they have demyelinating disease. This is a summary of some of the literature about the complications of infliximab. And we published years ago a paper about efficacy of infliximab in these patients, and the conclusions were the following. We found that infliximab, but this is the early period of using infliximab in our hospital. Infliximab is safe and efficient for long-term management of uveitis with patient disease. You can control also with infliximab the extraocular manifestations, mouth ulcers, genital ulcers. But the patient needs repeated infusions. This is not only 1 or 2 infusions. The patient will stay on infliximab infusion for a long time. And we noticed, like others, that it leads to rapid therapeutic effect, which is important in order to prevent ocular complications. The patient tells you next day that he sees better. It controls also cystoid macular edema. So that was the paper by first author was one of our residents at that time, Dr. Sultan al-Rashid. And at that time, this paper, we had the largest series of patients treated with infliximab from one center. I'm going to show you examples. Like this patient, retinitis, typical fluorescein angiography that we discussed, and after infliximab treatment. So these patients were keeping 20/20 vision. Like you can see this large patch of retinitis, and after infliximab, fluorescein before and after. This patient had cataract surgery without any complications. Perhaps this is a very good example. This is a patient with inflammatory central retinal vein occlusion in a patient with Behçet. As I told you, if you see vasculitis with signs of vein occlusion, this is inflammatory. And Behçet disease is the most common cause of inflammatory branch vein occlusion or central retinal vein occlusion. And this is after Niximab. Believe me, this patient, I'm still following the patient, he has 20/20 vision. So this is another case of inflammatory branch retinal vein occlusion and after infliximab. Severe vitritis, retinal vasculitis, retinitis in the macular area and after infliximab. I'm still following this patient. And this is a patient who was misdiagnosed by one of our colleagues to have acute retinal necrosis, because I told you, these large patches of retinitis can mimic viral retinitis, but this is Behçet disease. So the patient had severe vitritis, extensive leakage involving the capillaries, and after infliximab, we are still following up this patient with 20/20 vision. So the other anti-tumor necrosis factor alpha agent is adalimumab. Adalimumab is completely humanized anti-TNF alpha antibody. The infliximab was chimeric, part of the mouse origin. It has the same mode of action. It is given subcutaneously every other week in adults, 40 milligram every other week. Subcutaneous injection in children, 20 milligram, below 40 kilograms, 20 milligram. We prefer infliximab because we feel that it is more effective when the patient presents with active inflammation involving the visual segment. But if the patient becomes allergic to infliximab, because some patients after repeated infusions they develop anaphylactic reaction, they become allergic, then we shift them to adalimumab. Now, there was a hope that blocking the pro-inflammatory cytokine interleukin-1 might be effective. We have 3 drugs, anakinra, canakinumab, and gevakizumab. So gevakizumab was developed by an American company called Zoma, and they started a big multi-center study to study its efficacy in patients with active Behçet disease. They wanted us to be involved in this study. Even the representative from the company from France, Servier, was the company to produce it. They came to visit us as King Abdulaziz to visit the labs and so on. But then we told them we have a doubt that anti-interleukin-1 therapy will be effective in patients with Behçet uveitis, because when we did analysis of the aqueous humor, we didn't see interleukin-1. It was not present in the eye. So if it is not present in the eye, there is no benefit of blocking it. So we were not interested to participate in their study, but 6 months later, after starting the study stopped because of no efficacy. So this is an example that we have to even individualize treatment by examining the aqueous humor from these patients and see what kind of cytokines or chemokines are present, and then you give the biologics that will block this particular cytokine or chemokine. So this is, I want to leave you with this statement. The statement was published in Ophthalmology 2014 by a group of Reds experts, and the conclusion was that infliximab and adalimumab can be considered as first-line immunomodulatory agent for treatment of ocular manifestation of Behçet disease. You should not waste time. If the patient presents with severe uveitis involving the retina particularly, then you should start the patient with anti-TNF alpha agents, because these are the most effective drugs to stop the inflammation this patient. In fact, in Japan, they have this strategy of using anti-TNF-alpha agents as a first-line treatment for patients with special disease. Thank you very much for your attention.